The broadcast is now starting. All attendees are in listen-only mode.
Well, welcome everybody. Welcome to our webinar today on educational advocacy after brain surgery. My name is Pip Marks. I am the Project Director for Family Voices of California, and I'll be co-hosting today's webinar with my colleague Lilian Ansari. So just before we start, I introduce our wonderful speaker today. I wanted to just tell you a little bit about Family Voices of California. We are a statewide coalition of locally based parent-run centers working to ensure that children and youth with special healthcare needs receive quality healthcare. And as the state's affiliate of National Family Voices, we are California's federally funded family-to-family health information center, and we provide statewide support and resources to families of children with special needs. These webinars serve as a statewide, and as in today's case, a nationwide training on various child topics and are geared towards a very diverse crowd: families, professionals, parent-to-parent resource staff, advocates, etc. And if you have any technical difficulties, please go to GoToWebinar directly, as you see the number on your screen. And due to feedback issues from our end, we have everybody on mute. Throughout the webinar, feel free to type in your questions that you have in the little box on the right-hand side of your menu. And I believe Audrey is going to stop periodically to remove your questions. And this will also save time at the end. We will also save some time at the end for additional questions. And because of Audrey's presentation being so rich and goes quite deeply, we've decided to break this series into two parts. So the second part will be next Wednesday, June 6th at the same time. And everything is archived on our website, so feel free to, if you can't stay for both parts, feel free to go to our website after a couple of days after the webinar has aired, and then we will be having it posted on our website. And also, would you please take the time after the presentation to fill out this short survey that you'll be receiving in your email. It really does give us valuable information about how to make our webinars better, and I thank you in advance for doing that for us. So it is now my pleasure to introduce today's speaker, Audrey Vernick. Audrey serves as the Director of Educational Advocacy and Training and is responsible for coordinating the design and the development and the implementation of the Brain Recovery Project's Special Education Advocacy Program, which helps families navigate their child's individual education plans, IEPs, as you know. Audrey is certified by the Council of Parent Attorney Advocates. In 2003, Audrey's first son, Bennett, was born. And Bennett had suffered a massive stroke in utero and went on to have a hemispherectomy, I hope I said that correctly, at age 2. And as the parent of a child with cerebral palsy, Audrey shifted her career to that of as an educational advocate and caregiver. So Audrey, thank you so much for joining us. I am now have the pleasure of passing the presenter role over to you.
Thank you. Thank you. All right, here we go. Hello, everyone. Thank you for being here today. Thank you for that lovely introduction, Pip. And I hope I have people from many parts of the country. I do know that I had initially prepared this presentation for California. So if there's anything I say that is specific to California, I'll let you know. But in general, I look at the federal regulations to kind of shape the views here, so it should apply to all, but I'll let you know if there's anything specific. And so as Pip mentioned, my son is a 14-year-old who had a hemispherectomy after a stroke in utero, and we had many struggles in early education with him, and I shifted my career then to becoming a special education advocate, which has been a life-changing passion of mine. And the most important thing that I've learned is that parents and professionals that work with families with children with this level of disability need to be very well informed. So what you don't know what you don't know. So research and knowing as much as possible. So hopefully today I'll be able to give you a quick overview of some of the most important, the key points in terms of getting an appropriate IEP for your child. So I'm assuming that you all know what an IEP is. It's an individualized education plan. I'm going to not go into a lot of detail about the basics because I think I understand that most of you are aware, and there's some great resources out there that can help you understand the basic framework of the IEP if that's something you need more information about. This process is described by many parents as a battleground, and the advocates need to support the parents through this process, both logistically and emotionally. One thing that a parent said to me once was that it's like the basic rules of human engagement are thrown out the window, and some schools will delay services as long as possible in order to deny those services. And many parents feel like it's the absolutely worst part of raising a child with special needs. But knowledge is power. So if you're going to advocate for something for your child, you need to understand it. So the only way to negotiate with the school district for special education services is to obtain a comprehensive evaluation of the child. This is the accurate picture of all of the child's needs and abilities. So the point of the evaluations is to get that appropriate education. And if the people working with your child don't know and understand every aspect of their disability, they can't provide the appropriate education for the child. So you'll use these assessments to make decisions about goals, services, accommodations, and placement. So I'm going to outline the assessments that should be considered for every child after brain surgery in order to have a comprehensive evaluation. And remember, these kids are so rare. Most educators have never worked with a child with a brain injury or who's had brain surgery. So we need to give the educators as much concrete information as possible. So what you need to know is you need to know, oops, sorry, I went too far. You need to know about the brain. You need to know about your child's surgery and the effects of the surgery. You need to understand your child's disabilities. You need to know the IEP process, and you also need to understand interventions and teaching strategies. That's going to come much later. So start here, and don't worry, we'll get there. So one of the most important pieces we've learned over our past few years of doing direct advocacy through the Brain Recovery Project is the importance of a letter from the neurosurgeon or neurologist that's working with your child. So this would be a letter from the neurologist or neurosurgeon explaining why your child had surgery, what was the procedure, and then what are the effects of that disconnection or removal, or even if there wasn't a removal or a disconnection, if there was temporal lobe epilepsy that caused status seizures for many years, there's an impact to that portion of the brain. So what is that impact? Can the doctor explain in his letter all of the different areas that may have been impaired? And then this is other suspected effects of those impairments. We have a letter on our website that is from the neurosurgeon to for a child with hemispherectomy, which is our initial population was serving families with hemispherectomy. You can use it as a guide to help draft the letter, and then you would send it to your doctor and ask them to write it basically and address it to your school, and this will help form the basis of your request for assessments. So the brain. So we all are familiar with the brain. It has multiple folds and lobes, and there's all these different sections of the brain that control different functions. There's a lot of different types of brain surgery, and this talk was to be for advocacy after brain surgery. So I don't know what each of your specific brain injuries and disabilities are, so it's up to you to research and understand this. It's important to note that each lobe of the brain controls different functions, which are highlighted here on the slide. I hope you all can see it. But the frontal lobe is generally speech and motor. The parietal lobe is speech, taste, maybe reading. Somatosensory, that's the loss of body sensation, which can be common after a brain injury or brain surgery. And then the occipital lobe, which is the vision and visual association, and then temporal, which is hearing and auditory association, and also smell. But the other important thing to note, and this is one of my favorite videos, is that the brain is really a system of circuits or pathways. So yes, there's what happens, the implication of removing or connecting one lobe of the brain, but we also have to look at the overall effect of how that removal impacts the pathways in the brain, reading pathways and other neural pathways. I will say one other thing here, which is although every child is unique, there are some common challenges faced by a child after a large resection or a disconnective epilepsy surgery, and I will be going through these when we look at the assessment piece. Okay, I'm having a hard time moving on. I think I need to pause this. Sorry. Okay. The IDEA, most of you should be aware of this. This is the overarching law that basically provides an IEP, and it consists of these components. So the IDEA is the law that provides that children with disabilities should be educated, should have access to meaningful education through an IEP, a FAPE, which is the free and appropriate public education, in the least restrictive environment, LRE. It includes appropriate evaluation, which I've highlighted here because that's what I'm going to focus on today, and parent and teacher participation, also very important, and procedural safeguards. I do want to say something about parent participation. If you have not participated in a decision that was made about your child's IEP or the process, that's a fundamental IEP violation. So please don't ever second guess yourself. The parents are members of the IEP team, and it's critical that they have a voice. And the professionals that are working with families need to make sure that they know that as well. So this quote, I put in here, you know, what we want to focus on with this is that the law is present to ensure that there are high expectations for children and that we're ensuring access to the general education curriculum to the maximum extent possible. So in my advocacy work, I frequently deal with cases where, for example, the team doesn't want to align goals with grade level content standards. Well, that's not what the law says. The law says they do. So all children, including children with even significant disabilities, need to have access to the general education curriculum. And then let's look at FAPE just quickly. FAPE, what is FAPE? FAPE is appropriate. It's not the best education. It's not the Mercedes-Benz, but it's an appropriate education. So as parents, we want the best for our children. So we always say, well, I want the best outcome, but we're not entitled to that. We're entitled to an appropriate. However, there's also a difference between an appropriate education and doing damage. So if the child is regressing, not making progress, or all of their needs aren't addressed, that could be considered as doing damage to the child. It has to be based on the child's unique needs. And again, this is why the assessment piece is so important. And it has to provide meaningful educational benefit. If you're not familiar with the Andrews case, this was a Supreme Court decision that was written last year about an appropriate education for a student named Andrews. And if you search, there's a great parent power pack on understood.org about the Andrews case with Q&A. That's wonderful. It's an important piece of law that I think every parent who has a child with an IEP should understand, or anyone that's helping advocate. So the whole IEP process looks like this. We're referral, assessment, identification, developing the IEP, placement, review, and reevaluate. Many times when parents come to me for advocacy, they're talking about placement, or they're talking about reviewing the IEP and they've missed kind of the first 4 steps. So today we're going to focus on step 2. In the part 2 talk next week, we'll focus on the rest, which just gives you an indication of how important step 2 is. So step 1 is referral. Most children who have had brain surgery should already be referred for special education. This is anyone who believes that the child has a disability and might need special education services. So this could be a professional, it could be a teacher, it could be the parent. This is different than an SST or a student success team. The parent can request a special education assessment and receive those SST services simultaneously. And you can get that tier 3 while still in special education. So that referral doesn't preclude that student from having that RTI. The student is entitled to all of the same benefits that any student has access to. So anything that's available in the school for the students, unless it specifically says the general education students, should be available to all students. And many kids are referred to special education because of delays, but if a child has a clear-cut medical diagnosis that will impact their access to their educational curriculum or environment, they need the help and support of the medical professionals that work with them to understand this process and support them through it, and the parents have to request the evaluations. So we're on step 2, assessment. I'm going to take a breath, and I'm going to ask if there are any questions right now before I launch into, oops, sorry, that went away, before I launch into the bulk of my talk. So Pip, I don't know if you see any questions there, or?
There is one actually, Audrey. Can you hear me?
I can, yes.
Okay. So one parent, I'm a parent of a child who has had several brain surgeries and requesting an IEP after each one. Is this okay?
Okay, that's a great question. So yes, your child should be reevaluated every 3 years at a minimum. Some states, if their IQ is low or they have significant disabilities, it'll be every 2 years. You can request an evaluation every year of your child. And if your child has something major like brain surgery, absolutely they would need to be reevaluated, especially for something like a craniotomy of any sort. You can't expect that there's not going to be an impact on their function, and we won't know what it is unless we evaluate, right? So you maybe just did an evaluation 6 months ago. Your child now presents with epilepsy and needs a hemispherectomy, and then guess what? They have to reevaluate, and that is required by law if there's a significant change in the child's status. So absolutely.
Great, thanks, Audrey. One more. What if your child's very young and is already in early intervention, for example, that they're already receiving services from the school district that will transition into an IEP when they reach school age?
Okay, that's another very good question. Some of this stuff we'll cover in the part 2, but I'm going to touch on this here. So again, I want to know when the providers for that child right now in that early intervention program assessed your child, was that assessment comprehensive? Did you agree with the assessment? Do you feel like it really captures the full picture of your child's needs? If you answered no to any of those questions, then you have the right to request a reevaluation. We'll talk more about that process later. When the child transitions from preschool to kinder, from 3 to preschool and then from preschool to kinder, they should be reevaluated. Not every state does this, not every district, but as an advocate, I would advise you as a parent to request that reevaluation. Remember, you can request it every year. That's the minimum. I'm sorry, yeah, that's the because of testing fatigue and that sort of thing, unless there's a special circumstance like a change in status. So I would definitely recommend that when that transition occurs, you request that reevaluation, and you really want to be looking at all the possible areas of disability or impact, right? Yep. Anything else?
No, you can move on. Thank you.
All right, here I go. Okay, this is the big part. So, so number 1, what mommy wants doesn't matter. So mom, dad, professional, doesn't matter. That's, we love our children, but we're not experts. We want the best, and legally our children are not entitled to the best. Do you remember that? So we need the unbiased evaluations to obtain those appropriate services. And it has to be an evaluation, not a letter from your doctor. It needs to be have diagnostic measures. It needs to be comprehensive. And that's a really crucial piece, because you can walk into an IEP meeting and say, I know my child has problems with X, Y, and Z, and the team doesn't listen. And then parents are calling me, why aren't they listening to me? Well, what does the expert say? Well, I told them. You're not the expert. So what mom or dad, or even a professional working with a parent, wants doesn't matter unless there's an evaluation that states that that's needed. So the first thing you have to do is obtain that comprehensive evaluation in all areas of suspected disability. So in order for this evaluation to be valid, it must be comprehensive. The evaluation is kind of the overall look at the child. So it may consist of many different assessments. So you might have an evaluation of a child that includes 10, 15 assessments. Might have one, but then that means your child only has one area of suspected disability or need. So if you're missing an assessment or the assessment is poor, that means the IEP will be poor, because the IEP can only be as strong as the assessments. If it's not comprehensive, it's not valid. So the child can be assessed in any area of suspected disability and for any services needed to benefit from in school. So, and the important thing here is once the child is eligible for an IEP, you can ask for an assessment in another area. They do not need to meet the same eligibility criteria as they would if they were going for an initial IEP. So I often see kids that have an IEP for OHI because they've had brain surgery, and then they notice a speech impairment. So they ask for a speech evaluation and they are rejected because they don't meet the eligibility criteria for entering the IEP process with just speech. But that's not the way it should be done. The way it legally is required to be done is that the child, if it's an area of need that is determined by the team that needs to be addressed, then it can be addressed as a related service. It does not have, they do not have to meet the same eligibility criteria. Let's see here. So this child find is a part of the law. It's sort of a pain point for the district. Its evaluation is key. Even if you're not in a public school placement, you are entitled to have your child properly evaluated. You always want to request these assessments in writing. And as I said before, you don't need to meet the eligibility in the other categories once you're eligible for the IEP. So this is the most important part of the IEP. And I know I keep saying this, I'm a broken record, but I really want to hammer this home. You need the expert to discuss the strengths, weaknesses, and interventions. Any attorney is going to ask, what do the evaluations say? So this is where you spend your money. Let's see here. So here's another thing I hear a lot. That's medical. We don't need to do that evaluation. You have to get that from your doctor. Well, maybe. If there is an area of need that is going to impact the child's access to their curriculum or their ability to make progress in the general education curriculum, even if it's medical, they are required to evaluate. So if the school district says, well, we don't have a neuropsych evaluator, you can say that's fine. You can provide an IEE. That's an independent educational evaluation at district expense. So that is absolutely necessary. Okay, so what is needed after brain surgery? So I just want to remind everyone that most of these assessments are not normed for kids with visual, auditory, or motor challenges. Does that mean that they're not valid or we shouldn't do them? No, we still need the assessments, but we have to be very careful in the way we interpret the results, and we want to look at multiple measures for children that have any of those impairments to make sure that we're really getting a good picture. So we talked a little bit about the brain and the different parts of the brain and what they do. So what we'll see is impact to vision, visual impairments, orientation and mobility, visual processing, learning to read, mobility challenges, hearing and listening, behavior, cognitive processing, social skills, and then medical symptoms like hydrocephalus and seizures. So most everyone knows what a psychoeducational assessment is. It's the base assessment that the school district will offer a child when you request an IEP. And this is to include educational and academic performance. So this is an assessment that should contribute information about the processes that affect learning, thinking, and behavior. And this provides the basis for designing an educational plan that builds on the student's strengths and helps them to overcome their weakness. It's also an important assessment in the prevention of educational, behavioral, or social emotional difficulties through early identification of the special needs student, that's a really important piece, because we don't want those behavior or social emotional factors to get in the way of their access to their education. The psychoed will also assess for a specific learning disability, which is an eligibility category for being eligible for an IEP. So that would be a specific learning disability, a disorder in any of the basic psychological processes that are involved in understanding or using language, spoken or written, an imperfect ability to listen, to think, speak, read, or write, such as dysgraphia, to spell, to do math calculations like dyscalculia, and then including conditions such as perceptual disabilities, brain injury, minimal brain dysfunction, dyslexia, and developmental aphasia. This does not include ID, so intellectual disability is not assessed under a specific learning disability. An educational psychologist may consider autism and ADHD, but schools do not diagnose. So for a diagnosis, you need a medical doctor to get a diagnosis. I will talk about this more in part 2, but this is where you start, and then we're going to go on to the neuropsych in the next slide. So for autism and ADHD, I just want to make a note here. One of my colleagues mentioned that we need to really be careful about looking at autism and ADHD diagnoses with children with brain surgery or brain injury. We need to make sure that the vision and the auditory functions have been thoroughly evaluated before determining that a child has autism or ADHD. Autism is characterized primarily by not being able to make eye contact, and that's one of the primary issues. Well, so is CVI, a cortical visual impairment, which I'll talk about a little later. And then auditory ADHD, it's inattention, it's the inability to focus, and that's exactly what central auditory processing disorder looks like. So that's why I want to make sure we get a really thorough look of each of the different really basic processing abilities after any surgery. So the neuropsychological assessment, this is the most important assessment. If you were only going to get one, this is it. This is the tool for communicating to the school what your child's IEP should entail and how to teach your child based on how his or her brain functions. So this provides the most comprehensive and accurate picture of the child's cognitive and learning profile. It describes how the child's brain processes new and novel information. It describes the child's cognitive strengths and weaknesses in detail. It's extremely useful in the educational planning for students with developmental disabilities, and it's more extensive than an educational psychology evaluation because it assesses all areas of functioning in detail, and it can provide intervention recommendations in each unique area. So a neuropsych assessment should look at all of the areas that I listed before: hearing and listening concerns, cognitive processing, social skills, attention, working memory, cognitive processing, sensory motor capabilities such as sensory functions, fine motor, visual motor, all the cognitive processes, and then acquired knowledge, which would be that academic achievement. So if the child is 5, they may not have as much of an academic knowledge base, but by the time they're 10, they should have a measure of academic achievement. Okay, another one, reading. I feel as an advocate that reading is one of those skills that defines the future life of any student and the degree of independence. So by the 4th or 5th grade, education shifts away from the concrete to the abstract, and this is a major obstacle for any child with brain damage. Reading becomes about what one knows about the world, and the amount of what's written between the lines increases exponentially. The ability to get the big picture is compromised on all levels, from spatial to critical thinking. This is so important for teachers to address, especially as the child enters middle school and the education shifts away from that concrete to the abstract thinking. And comprehension can be a challenge regardless of what type of brain surgery. Sometimes these kids can read, but they don't understand what they're reading. So reading to learn subject matter becomes very problematic. In order to prevent waiting till middle school to find out that your child is not reading or has deficits in reading, it's very important to get a comprehensive evaluation of reading. You can search the term diagnostic reading assessment which is different than the Diagnostic Assessment of Reading, the DAR, which is an actual measure. A diagnostic reading assessment, which was, the term was coined by a panel of reading experts, and I'm sorry I don't have the citation for which panel with me, but that's an assessment that's valid and reliable based on scientifically based research and used to identify specific strengths and weaknesses so that the child has learned to read by the end of grade 3, and determining any difficulties the child may have in learning to read and the potential cause. So this would include the essential components of reading: phonemic awareness, phonics, vocabulary, reading fluency, which includes oral reading, and reading comprehension. Now you might say, well, my child is only 5. We can't possibly assess in all these areas. There are pre-literacy measures that can be done that for children as young as, I believe, 3. So there are absolutely measures that can be done. Early language skills, early language acquisition, this should all be screened. If the child has an auditory or visual impairment, this type of assessment is even more important, because there may be something getting in the way of the child being able to access reading. Without an evaluation, we will not know. So, okay, I'm going to go on to the next slide.
Actually, Audrey, there was a question that came up when you were talking about the neuropsych evaluation. This person is asking if it's an independent neuropsych evaluation, but the costs, who covers the costs? And oftentimes insurance will not cover it, especially for children on Medi-Cal, even though it's been prescribed by a neurosurgeon. Can you talk about this?
I can talk about that a little bit. It's tough. Locally in my direct advocacy, I have found a network of sources that provide free or low cost neuropsych evaluations. So it takes a little digging, but they're out there. And some of them are quite good, and they're often overseen by licensed neuropsychologists. They're not just students winging it. So they can contain all the relevant components. The next thing would be to go to the Pediatric Neurosurgery Center where the surgery was performed and get the evaluation through that. I understand Medi-Cal can be tricky and that might not be able to be covered, but I would work with your social worker in the hospital to help figure out if that's something that can be covered. But honestly, the school is responsible, remember the child find law, to evaluate your child in all areas of suspected disability. And if your child has any neurological impairment, they must have a neuropsychological evaluation. So you would request in writing that the school district provide a neuropsychological evaluation. They would contract with an independent evaluator, and that school district would foot the bill for that evaluation. This is the most important piece that you can get. So it's absolutely important. Now that I have this question, what I'll do is in part 2, I'll be sure to have a slide on how to ask for that and what language you need to use in that request. I can't pull it up right now, but I will have that for you.
Excellent.
Is there anything else, Pip?
Nope. Not
okay, great. All right, so this slide on circuits, you've probably all read while I was talking. I just found this so interesting because we sometimes think about the reading center of the brain, or, if this side of the brain is missing, then they're not ever going to possibly be able to read, that sort of thing. So, the brain has to fashion new circuits between these parts. Sometimes that's very challenging for kids that have a disruption in any aspect of their brain function. So again, we want to know what the deficit areas are and how to accommodate them or modify them so the child can still access reading, which is the most functional part of communication they need to learn in school. So we want to look at things like language comprehension, word recognition. Are they strategic with their reading, or are they automatic? Are they skilled readers? Do they have a fluent execution and coordination of word recognition and text comprehension? And then the other really important factors with reading is that attention, executive function, memory, the visual motor, oral motor, because their oral reading fluency will be low if they can't speak well. And then that auditory component, which I'll get to. And we want to think about the language having that form, the content, and the use. So the networks in the reading brain are the anterior network, which is and includes the inferior frontal gyrus, for those of you who are brain geeks like me, and then the posterior, which is the dorsal network, and that supports decoding skills, and the ventral network. So again, knowing from your neurosurgeon, have your neurosurgeon really explain what parts of the brain were removed, what are the impacts, and also know that the surgeon may not know all of the impacts, as crazy as that sounds, and you might have to do a little research and a little digging to really understand it, but you want to know what networks were disrupted, which lobes of the brain were damaged, what was touched, and what are the impacts going to be. So I've mentioned a couple times the visual and auditory. I think they're the key, other than neuropsych and reading, components to look at after brain surgery. Motor is obvious. So we see motor. We see a motor impairment, but we don't see often the visual and auditory impairments, and they can be a huge impact on the child's ability to access new information. So there's something called a foundational tripod. If one is off, the whole system is off. So when I get to the occupational therapy section, I will talk a little bit more about the foundational tripod. So we're going to start with vision. Vision consists of different things. There's acuity, which is how sharp the vision is. There's the visual field. So if you've had a portion of the brain removed, you may have a loss of visual field. So the occipital lobe would result in removal or disconnection, would result in a homonymous hemianopsia on the opposite side of both eyes. Even a temporal lobectomy could result in a quadrantanopia, which is a quarter field loss. This is a really important thing to assess. It's very hard to assess sometimes in younger kids or kids that are not able to sit through these kinds of assessments. So you'd want to see a neuro-ophthalmologist to really talk about the possible implications and, again, what accommodations could be in place. And then functional vision, which is what the school district will do. So your child may have a cortical vision impairment. That means the eyes can see, but the brain can't. So our eyes function to take in that information, but the brain makes sense of the information. And you can see here in this slide, the information we receive in the right side of the eyes goes in and crosses over to, sorry, I'm backwards, into the right visual cortex, and the opposite. So, and we also have to make sense of that information. There might be that field loss, which could impact the child's orientation and mobility. There can be acuity issues, in addition to all of the other things. And there also can be ocular motor issues, which affect reading. So I think of ocular motor issues as CP of the eyes. So we know what cerebral palsy looks like in the body. If the motor strip is damaged or disconnected, the child's going to have a resulting motor impairment. But we forget about that the eyes have many muscles. And if you disconnect or remove any portion of the motor strip, it can impact the ocular motor function. Also, the field loss can also impact the ocular motor function, because if your brain repeatedly does not get that information, so if you just look at the slide, all of the green information is gone because there's not any information getting to the brain from that the left side. Now the brain just says, well, okay, there's nothing there. I don't need that field of vision anymore. And we often see like a drift and exotropia or esotropia. One eye goes out to try to expand the field of vision. So this is a really important issue as well. And then there's also visual, spatial, and visual perceptual deficits that can affect math, or any activity that requires visual, spatial, and visual motor skills. So the school district assessment is going to be pretty basic. It's going to be conducted by a TVI, a teacher of the visually impaired. They have different acronyms in different states, which evaluates how the child uses their vision for near, intermediate, and distance tasks. But it's not going to be a very comprehensive evaluation. I know in California, UC Berkeley has a low vision clinic and a binocular vision clinic. I'm in the Bay Area. I'm sure there are these types of clinics and centers in other areas. So that would be something to really look at. And again, asking your neurologist to refer you to a neuro-ophthalmologist to really understand the implications of that. Let's see here. So I want to talk a little bit about visual processing. So this would be assessed by a neuropsychologist a neuro-ophthalmologist, a developmental optometrist, and I didn't put on here an occupational therapist, but occupational therapists also look at visual processing. So the signs that the child might have a visual processing difficulty is they avoid difficult puzzles. They are very auditory. So you tell the child and they know, but they can't read it. They spell phonetically. They have poor reading comprehension. They memorize facts. They're sort of a historian, but they can't access visual information. And they do well in practice, but not in performance. So you really want all those different areas looked at by a skilled clinician. And just a couple other slides about the visual processing streams. Remember, I've talked a lot about the networks and the circuits in the brain and how does it all connect. So again, if your child is missing or has damage to a portion of the brain, you need to understand what are the implications of that. And that's what your assessments need to uncover. So the visual processing and perception issues can be assessed by the neuropsychologist. They can perform tests to see how your child's visual issues are affecting the development. And then also those additional tests to measure the intelligence and academic skills, language skills, etc. And this is one just about the visual processing centers in the brain, and it looks at the ventral stream and the dorsal stream that I mentioned earlier. So again, these are important areas to understand so that you can advocate appropriately for your child or the child you're working with. And this is just one of my favorite slides. It's the Gestalt, and I never really knew what Gestalt meant until I was well into adulthood. This looks at all the different areas that can be impaired in visual processing. So we think of visual processing as not being, it's not really talked about very much, but with brain injury, brain surgery, this can be impacted. So you can see here all the different areas that may be impaired if there's a visual processing issue. So orientation and mobility. This can be, would be an assessment you need if the child does have a vision impairment or a field loss, and that's going to look at the child in the different environments. And lack of binocular vision, so if the two eyes don't work together, can affect depth perception, and it also can affect the child's ability to measure distance, which can be important for things like crossing the street, safety when crossing the street, or even shifting focus from reading something at their desk to reading something at the board. So if you have those concerns about your child's ability to move safely and independently in their environment or accessing curriculum, then that would be it would need to be with an O&M specialist. So hearing and listening, I could do, and I have done, hours of conversation about this topic. So hearing and listening are two different things and two different functions. So there's hearing acuity, just like there is visual acuity, which you would do an audiogram, a pure tone audiogram. But then there's auditory processing. What does the brain hear? So acuity is that standard hearing test, that pure tone speech testing. But the central auditory processing disorder, it's like the vision, which we spoke about earlier. It's how does the brain hear? So the peripheral hearing might be intact, the ears, the cochlea, leading all the way up to the brainstem, everything's fine. So the information getting in is fine. It's what the brain does with the information once it gets there. And again, central auditory processing disorder can often be confused for ADHD and other issues. So if the child has had any impact to the temporal lobe or a disconnection of the corpus callosum, you absolutely have to have a comprehensive audiological evaluation looking at central auditory function or central auditory processing disorder. The type of assessment that would be done would be looking at things like dichotic listening. That's how do you hear in a multiple sound environment. So when it's noisy, localizing and lateralizing sound, that's being able to hear the car coming, which direction is it coming from when you're crossing the street, the overall acoustic scene. And this testing generally has to be done at age 7. There are some exceptions in ways that can be addressed earlier, I would definitely request the evaluation as soon as possible if you have any temporal lobe or corpus callosotomy issues. I'm going to go quickly because I see we're running a little short on time and I still have a long way to go. Just one more point here is the child with a central auditory processing disorder may show symptoms like they're easily distracted, or unusually bothered by loud or sudden noises. They get upset in noisy environments. They have difficulty following directions. They struggle with abstract information like math word problems, difficulty following conversations. So central auditory processing disorder acts like an acoustic filter that distorts the reception and or interpretation of verbal language. And you can see how important there that corpus callosum is for that interhemispheric transfer of language, and how any information going in the right ear goes over to the left temporal lobe. Any information going in the left ear goes over to the right temporal lobe. So they're both, those temporal lobes are critical for making sense of that incoming information. Gross motor skills, most of us are aware of what PT is, so the physical therapist should be looking at mobility and functional abilities. That includes so the balance and coordination, equilibrium reactions, static and dynamic balance reactions, motor planning. Core strength includes things like staying active and limber and having postural control and being able to do transfers to or from the floor or to or from a wheelchair or from a wheelchair to a standing desk, that sort of thing. The physical therapist should assess the need for and the use of the assistive devices like a walker, a wheelchair, prosthetics, orthotics, etc. Assess bracing and gait, and then use activities to improve, maintain, or restore the child's functioning. So that would be any kind of gross motor development that has to do with ambulation, which is getting around, the balance and coordination in different settings. And so you have to think about all the settings where your child might need, have a difficulty with their physical ability to access the classroom, the gym, the bathroom, the playground, a staircase, a transition between classes. That school-based PT should promote the motor development and the students' participation in everyday routines and activities that are part of their educational program. Related to this is adaptive PE. This assesses the child's ability to participate in their school PE program and access their school environment. This includes, health and well-being, including social group and interaction skills, play and leisure skills, social emotional development, peer interactions, sportsmanship, all of those things that happen in PE that don't happen while you're sitting in a classroom listening to a teacher. And then also the functional gross motor skills in relation to mobility and play, endurance and conditioning for physical fitness, balance, body awareness, etc. So the APE teacher is generally an educationally trained professional who's able to assess the student, to develop, adapt, and implement a specialized PE program in the motor domain. Now, one clarifying point here, the adaptive PE teacher is a direct service provider, not a related service provider, because physical education is a federally mandated component of special education services. This means that PE has to be part of the child's program. That has to be provided to a child even with a disability. This is contrasted with PT and OT, which are related services, so it's a little bit different. So for OT, this is sensory processing, gross and fine motor, and then visual motor. I talked before about that foundational tripod. The foundational tripod is how we use our auditory, visual, and vestibular systems together. So if you have a tripod and that's your foundation and one of those legs is missing or damaged or impaired in any way, it will impact the child's ability to overall access information, to be alert and attentive to instruction, those kinds of things. So this is a really important component. I see that the school-based evaluations are often limited. This is another one where if you have a private OT evaluator or you go through a children's hospital clinic, you may want to get an additional assessment outside of school and bring that information back to your team. Sorry, I have a lot more here, but I don't want to go over. So for OT, you want to look at the medical and the school implications. Your child can have school-based and private OT services concurrently. If your school district says they can't, they're wrong. You want to write goals for the school setting that are based in the school setting and goals in the medical setting that are not the school-based goals, but you absolutely can have both. And you want to look at all of those: sensory, gross, functional, fine motor, visual motor, balance, vestibular, motor skills, and then all those underlying sensory processing abilities, which I think most children who've had brain surgery have an impairment in that area. Really understanding sensory processing and regulation is another important piece. This is the part that's often overlooked by school-based OTs. There are some standardized tools that can be used to measure the child's sensory processing ability. You can ask your occupational therapist to include standardized measures of sensory processing in their evaluation. They may not do it automatically. So again, that decreased foundational body awareness provides that unstable tripod for the reception of that environmental information. So that means one leg of your stool is missing, you're going to fall over. So we really need to understand what are all of those foundational senses, are they all working properly? Speech and language. Okay, so we've got looking at all the different areas of speech and language. So there's using speech and language, which can include articulation, nonverbal communication, which include understanding pragmatics, like what's not said, and then all that phonology, morphology, language meaning that's going to help with those reading, acquisition of reading skills. Augmentative and alternative communication should be assessed. Generally, this is considered for the child that is nonverbal. I would also argue this is an important evaluation for the child that is pre-verbal. It can often be a bridge to verbal communication. And sometimes schools won't want to use it if the child already has some words and they say it's going to get in the way and hinder their ability to communicate, and that's not what the evidence shows. So that AAC assessment should identify communication options for the person with a communication impairment and determine the technology that's needed. That could be a speech generating device, computer software, a keyboard. This is another biggie. I could spend an hour just on this. This is required by law. It must include an evaluation if the team does not feel they have the tools to provide the appropriate services and technology to the child. So assistive technology evaluation would include an evaluation for tools, devices, and service. Oftentimes I see AT reports that recommend the kid gets an iPad and a pencil grip and a rubber band around their chair. Thank you very much, and they're done. No. What is the service involved in helping the child understand how to use the iPad? What educational apps are going to be on it? Is there eye gaze software needed? Are we going to monitor what type of keyboard the child is using and which one is the most effective, especially if the child has even a mild motor impairment? So I'm going to move on. Like I said, I could talk for an hour about this one. You can let me know if you want more information about that. Functional behavior. This is looking at the understanding of the relationship of the events and the circumstances that trigger and maintain the problem behavior. Now, often what I hear from parents about FBAs is, oh, the school won't do that because he's not throwing furniture across the room. He doesn't really have a behavior problem. But then in the same meeting, the OT will say, well, the child can write. She's just choosing not to write. So I don't need to work with her anymore because she's capable of doing it. She just doesn't want to. Ding, 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 ding. There's your behavior. So a maladaptive behavior is any behavior that prevents the child from accessing their curriculum. So if the child is refusing to write, maybe because writing's difficult for her, that's a behavior that needs to be looked at in the FBA. What are they tuning out in class? Are they not paying attention? Do they have to go to the bathroom 15 times an hour? That you really want to be looking at any behavior that impedes the access to them being in their education environment and accessing their curriculum. Mental health, this is conducted by the school district psychologist, and it determines whether the disability is serious enough to warrant a special mental health and therapeutic intervention to help the child make friends and socialize appropriately. So this may be covered under an experienced neuropsychologist, can pinpoint different areas of deficiency and identify necessary strategies. But this is also something you can request independently of that. Honestly, myself, I was very apprehensive about the word mental health, and I didn't think my kid needed any mental health services. I feel that any child with a disability warrants mental health services before middle school, and definitely through middle school. My son ended up starting mental health services in 4th grade. What that means is a school-based counselor that's checking in with him once a week, checking in with the team, making sure that if there's social concerns, how are they being addressed, helping with goal development. So you can think about how many ways that service could provide a bridge for those social and pragmatic deficits that we often see in our kids. And then lastly, health. So health is usually the school district nurse. I would like to see an individualized healthcare plan developed as part of this child's IEP. Oftentimes I see schools saying, we'll attach the IHP, the individualized healthcare plan, and then nobody can ever find it. So I also like to cut and paste the entire individualized healthcare plan into the IEP. So this would look at all the child's medical needs. What medications are they on? Is there any seizure protocol or shunt failure protocol that needs to be followed? And then define the access to the health and nursing services for this child. So does the child require that there be a dedicated nurse at the school? Does the child require that there be a nurse sitting next to the child all day long? Or is it okay if the child has a nurse at another school in somewhere else in the district? That's where you want that really clearly spelled out. Okay, whew. I've got 5 minutes, so I am not going to be able to get to how to ask for an independent educational evaluation. Just know that you can, and the basic summary of how to ask for it is you say, I want an IEE, and they either say yes, or they take you to due process. That's it. You do not have to give any more information. You can, but it's not required. But I will go into a more nuanced description of requesting an IEE at the next talk. And I'm also going to talk more about the problems with evaluations that we see and what would lead you to request an IEE. And then we'll quickly go over the IEP process in the next talk. But for now, I'll answer some questions and you can let me know if there's anything else. I'm going to go to the end here and you'll see all that next time.
Fantastic, Audrey. I know. This is why we're having part 2 next week.
I know. I knew it was going to be too much.
No, it's been fantastic. There was a question about going back to assessments.
Yes.
This person is asking and commenting and saying, isn't the parent's observation of the effect of seizures and or medication on their child's cognitive abilities, etc., a valued part of the child's assessment by the IEP team as it determines the child's goals and educational placement?
No.
So okay.
Honestly, no. I mean, I don't want to be cavalier about this. So the law, IDEA, states that the child as a parent is a member of the IEP team. Parent participation is very much strengthened right of IDEA when it was reauthorized in 2004. So yes, the parent has a right to participate in the IEP team, and they should comment on what they're seeing at home and what the impacts are. But if you don't have an evaluation that states the impact, then it's going to be very difficult. You have no legal recourse for sure. Now, it might be that your child can't undergo a neuropsychological evaluation because they're nonverbal or they're just not cognitively able to undergo that evaluation. That doesn't mean you don't pursue it and get as much information as possible in the evaluation report. It may state this child had this portion of their brain removed, and as a result, they have X, Y, and Z. And therefore, accommodations and services should be provided in X, Y, and Z. So I'm sorry to say it, yes and no. So yes, you have the right to speak to your child's needs and you do know your child best. But without the evaluation, and it has to be, again, an assessment, not a letter, that states the impact of the surgery or epilepsy or whatever on your child, it's very difficult. You won't have any weight in court. Now, most of us aren't going there, but even working with your IEP team, it's important to consider what are they going to listen to and what are they going to take into consideration. So if you go to your team with this personal information and they're not listening to you, well, what's your recourse? If you don't have an evaluation that agrees with what you are seeing, it's very, very hard for you to have any recourse as a parent.
Wow. Okay. Well, there's another question, Audrey, about asking for a one-on-one aid, but I think that might be best suited for next week's webinar.
I can touch on that quickly.
Okay.
I meant to mention this under the FBA, the Functional Behavioral Assessment. Generally, this is where we would get that one-to-one aid, is through that Functional Behavioral Assessment. So if the child has not had an FBA for any maladaptive behavior, that's what you want. And remember, we'll touch on this next week, but if you don't agree with the evaluation or it's not comprehensive, so say the evaluator says, oh, the child shows no difficulty of accessing any component of their education in the FBA, but you know this child tantrums every day, can't pay attention for more than 30 seconds without someone redirecting them to task, is not making grade level progress on academics or anything, well, I would disagree with that evaluation. So that would be your starting point for a one-to-one aid. Again, you can ask for one. You can say, I know my child needs an aid. My child needs an aid. My child needs an aid. But unless you have an assessment that really outlines the need, it will be much, much harder. It's not impossible, but it's much harder to get that.
Wow, that's great information. I think that it's time to bring a close to this week's webinar. Audrey, thank you very, very much. And I just want to remind everybody that's attending to please fill out the evaluation survey that you'll receive. And I'll also be sending you all a link to register for next week's webinar, part 2. So we will talk then. Thank you, Audrey. Thank you, everybody, for joining us today. Bye-bye.
Thank you. Bye-bye.